Welcome to this episode of the TelePT Connections podcast. I'm Daniel Seidler. Thank you for all your comments on LinkedIn, Twitter, and your podcast apps. They mean so much to us. Please continue to comment and be sure to subscribe to the podcast. This week, we're joined by Jan Ground. Jan led innovation in virtual care at Kaiser Permanente Colorado, where she worked for 18 years. Currently, she's the Colorado Liaison to the Southwest Telehealth Resource Center and the Colorado Ambassador to Telehealth and Medicine Today, an online peer-reviewed journal. Very active with leadership roles in the American Telemedicine Association, Jan leads a group looking to prove with the use of data that telehealth is worth paying for, even after COVID-19. And telehealth is not just video visits, which we know. Ms. Ground's greatest expertise is in leading change, a significant need in implementing virtual care, and in working with leaders to clearly define a measurable problem before implementing a new approach to care. Her greatest passion now is working with healthcare leaders to lower the cost of the American healthcare system without lowering clinical outcomes, or improving clinical outcomes without increasing the cost. Jan led Kaiser Permanente Colorado's first innovation team, and she's an expert at asking provocative questions that lead to viable solutions and 360-degree buy-in. In this episode, you'll hear Jan work her magic, and I'm sure this discussion will make you think about how you approach innovation and change in your life. Remember, please subscribe to the podcast, and we hope you enjoy this episode.
Welcome to the TelePT Connection Podcast. Physical therapy information, innovation, and insights for patients and providers. Physical therapists and innovators Dan Seidler and Adrian Miranda will help you connect with your neuromusculoskeletal system, discussing how to care for every physical ailment they've ever seen or heard of, the latest digital health technology, and other fun stuff from their PT toolbox. Great guests, 21st century home remedies, exercise thumbs up or thumbs down. Now, here are your hosts, Dan and Adrian.
Okay, welcome to the TelePT Connections podcast. I'm Daniel Seidler.
I'm Adrian Miranda.
And our very special guest today is the lovely Jan Ground. Welcome, Jan.
Thank you. Nice to be here.
Great to have you here. So, Jan, I'm pretty sure we met through LinkedIn, just telehealth connection. I had looked you up and reached out to you. You were gracious and nice, and then I started seeing you everywhere. So every American Telemedicine Association meeting that I went to, you were there. You were at other meetings that I was like, who is this person? Why is she following me around? Or was I following you around? Maybe I'm not sure. Every time I talk to you, Jen, I feel like you're in a different, that's our sort of ongoing, our inside joke, right? That you're in a different city, a different place. Today in Colorado, right?
Yes.
Lovely Colorado. So
yes.
Welcome. Jan, you. I know you're very active in the American Telemedicine Association. What's going on there these days in your sphere?
Well, it's fascinating. So I led telehealth or virtual care for Kaiser Permanente until I retired from full-time work a few years ago. I would say at least 10 years ago we started it. And so I've been a member and active in the ATA for many, many years. And it's changed a lot over the years. Primarily, I guess it's gone from a lot of individual members to it's much more focused on very, very large organizations. I imagine it's financially driven, which makes sense. And so I think that's the big change I see. In terms of more detailed stuff, there's all kinds of special interest groups. We call them SIGs, as Dan, you know very well. And there's all kinds of SIGs, and they've added a lot. So these are basically subcommittees. And there's ones for specific types of medicine, like there's one for ocular, there's one for pediatrics, there's one for rehab. There's one for, I guess those are the three that I can think of that are specific to specific specialties. Most of them are more process-oriented, like, there's one for mental health, but there's one called business and policy. There's one called the Interstate SIG.
Interstate, I'm in that one, yeah. And and you're right, it is a lot about just the operations and policy of telehealth. But the rehab SIG is trying to make a push to I guess to normalize telehealth in the rehab space. And the last few meetings have been pretty interesting. I mean, I think that, well, we did a presentation, which I think was very well received. Myself and a couple of other PTs, Jared Goldstein and Adine, I can't remember Adine's last name.
Turner.
Adine Turner, thank you. They have their own telehealth PT practices. So the three of us presented to the group. And I thought it was pretty well received. I thought we had a great conversation after. And it's interesting because, as you said, a lot of the members of the ATA now are part of large health systems or they're vendors in the telehealth space. So it's a little challenging for smaller practices. But that also became part of the conversation, which I think the ATA is going to they're addressing now. They're looking to see how they can involve smaller groups and smaller players, smaller practices. I hope that works out. I mean, it makes sense to me.
And I think actually telerehab is an interesting place because I would guess, having learned a lot from you and Jared and Adine, that the only folks or the folks that are leading this world into telerehab are not in big health systems.
Right.
And so if that SIG, the special interest group, is going to succeed, I would suggest it's really important for people like the three of you to get involved and to remind them small businesses in this particular case are driving it.
Interesting. And hopefully we can attract other practices like ourselves and groups like ourselves and practitioners like ourselves. Adrian is very involved. Adrian is a telehealth practitioner as well. And, we definitely talk to a lot of people who do the same sort of practice. But you didn't start, actually you spent most of your career in a large health system. Talk about that experience. I mean, you were the director of innovation at Kaiser Permanente Colorado. Do I have that correct?
Yeah. So let me just back up a little bit. So I did start my career as a pediatric physical therapist in 1980. I'm giving away my age. And I practiced for 6 years in children's hospitals. So I never took care of people in the aging group. I got a master's in exercise physiology and I was director of health and fitness for an adult hospital. And then did some consulting for consulting firms with a brand new MBA, blah, 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 blah. And eventually I moved to Colorado, worked in leading change, which is my passion, leading change with Blue Cross Blue Shield for a couple of years. And I joined Kaiser Permanente in 1999, and I retired from KP in 2017. I did a wide variety of things early on in those 18 years, but I would say the last 10 years, so if I was left in 2017, I'm guessing as far back as 2006, 2007, I led the first innovation team. So I wasn't the director, I was the project manager, but I led the innovation team. And then I led a group called the Emerging Technologies Advisory Group. And finally, my boss, an executive physician, wanted me to focus specifically on virtual care, which my soapbox is virtual care is not just video visits. And so I led telehealth or virtual care for probably the last maybe 7 years of my career there.
Oh, I want to get back to that, but let's go back to, first of all, how was your experience as a pediatric PT? I skipped over that, but I think that's really important, right?
Absolutely. So when I went to college, I went to a small liberal arts college, wanted to be a teacher. And then I volunteered at a children's hospital one summer, and that was it. I wanted to be a PT, and I only wanted to work with kids. I love children's hospitals. Everybody who works in children's hospitals are so committed to kids. And by the way, I don't know if you know this, Dan, that I now volunteer at Children's Hospital here in Denver. Once a week, I hold babies in the NICU for 3 hours every day since I'm retired. Anyway.
That's awesome. That's rewarding for everybody, right?
Yeah.
Wow, cool. Very cool.
So I loved it. I loved working with little kids. What I remember is because obviously during our training, and I trained a lot further time ago than you guys did, we focused mostly on adults and older people with strokes and heart attacks and all kinds of other things. And what I loved about working with kids as a pediatric PT was that kids wanted to run around. So if they broke their leg or if they had heart surgery and we needed to get them going again, just let me go. I don't want to stay in this chair. And if they were hurting or if they were sore or something, all I needed to do was bring out games and toys and show them something cool to do. Today it would be obviously a tablet, but give them something fun to do. Fine. And if I saw a baby with torticollis, all you need to do is put the toy on the other side and they're happy. Well, my experience with older people is
That's
not
simple,
so
huh?
It was.
PT is really simple sometimes, I know.
For babies it is. For young kids it is.
Grown-ups too. So from there then you got into being a project manager for innovation. And like how'd that arise, and like what was your background to be qualified to do that?
That's a really good question. The only thing I could say is I worked for Anderson Consulting, now Accenture, for a couple of years, and they had developed the expertise in me in leading change. And I think I worked for the medical group of KP at that point, the Colorado Permanente Medical Group, and my executive physician boss really wanted to see innovation take off. And I think he just thought I had the right personality. I co-led it with IT leaders. And for the rest of my career with KP, I had an IT partner by my side because obviously, like you guys, I'm not an IT expert. Right. I'm a clinician. So
you can speak for me, but Adrian, on the other hand, he's got skills.
But I understand what you're trying to get to. I wasn't always as savvy in technology, but yes, I understand what you're trying to say.
It's an interesting point, though. I think a lot of people think about innovation and working in sort of a technology space. You have to be a techie or you have to be a coder. But the quality that you bring to it, and I know this from our previous all of our conversations, Jan, is you're an outside the box thinker, and not just like wild and crazy ideas, but like organized, structured ideas that are a little bit different than everyone else, the way everyone else is looking at things.
But what I feel you bring to the table is the communication to the IT. I think that's what you bridged for the healthcare, rehabilitation, and technology, which is, I think that's probably a more important gift than actually knowing the technology. So I think, I'm sure that's what you bring to the table is that communication. You're clear, you're direct, you know the vision, and that helps, right?
I think we need it all. I mean, I certainly couldn't do what I do or did without IT experts. And my greatest expertise is leading change. And as we all know, but I know it best from Kaiser Permanente, I implemented video visits with Kaiser Permanente physicians, advanced practice nurses, PAs, and then eventually all other kinds. They didn't want to do it at all. And so I can tie this together with my leading innovation. The biggest thing that I've learned in motivating people to do things differently, and I've only done it in healthcare, but if I talk to lawyers, it'd be the same thing, is to understand a problem that we're trying to solve that is meaningful to those that you want to do something different. And we didn't have that enough for the docs at the time with video visits. We eventually got it going when, for example, Kaiser Permanente expanded into the mountains. And that was a long drive for the specialists. And they had to go out there X times per week or X times per month. And they didn't want to, and it was a waste of time with all the driving time. So then they understand we've got a problem to solve, and video visits started to pick up. But primary care and the ones that were being seen just locally where you didn't have to drive very far, from a physician's perspective, there was no problem to solve for which we needed to do video visits. And of course, COVID changed all that.
What did you have other ideas about about problems to solve? Meaning I think that telehealth solved problems. I thought it was a good solution for other situations besides a pandemic.
Well,
how did you try to get that point across is really the better question.
My opinion at a very high level, and Dan, I think you know this, regardless of whether it's TelePT or tele anything, is we have a long way to go to prove that care by video or email or phone or remote monitoring, social media, mobile apps, AI, all of that is virtual care. Care in that way, we have to prove that we're either lowering the cost of healthcare, because maybe you guys, because I'm not a clinician anymore, you guys can see more patients without necessarily getting paid more, which I know will not make you happy. But if we can lower the cost of healthcare and get the same clinical outcomes, or maybe it's or we can improve the clinical outcomes without increasing the cost of healthcare, it's worth it. But we have a long way to go to prove that.
Sure.
Intuitively, I think it's the right thing to do, but I think we need to prove it. What do you think, Adrian, of what I just said? And I'm pretty radical.
No, I think it's wonderful. I guess I was going to take you like a step back and ask you, because there's a lot of clinicians who are difficult they adopted during the pandemic, but then they pulled back once in-person happened.
Absolutely, yes.
If we want to do that, we need to have a large number of clinicians willing to do that. We create data, we prove it. I don't think we have enough clinicians. So what's like a 10 bullet point list that if you had a room of tons of clinicians to convince them to that virtual care, it could be lucrative. Lucrative is a strong word, but it's a medium to help more patients, and eventually it might help our profession and our income as well. But like, what are like some tips? And part of it is because of if you did it at Kaiser, at a large institution, like what did it take to change those perceptions? Because I'm sure there was like case studies. Physician A didn't want to do it because it was a long drive. Physician B didn't like computers. Physician C loved it, but they were clueless how to use it. Like I'm sure there was like 100 different case scenarios. So like in today's era, if you had to speak to all the clinicians who are a little bit reluctant, what are like some 10 is a lot, but like 10 bullet points that you would say, this is why you should adopt it, and go?
Well, just sure. And you're going to have to interrupt me because I could go on and on and on. So please interrupt me.
I will.
That's
of all, my job.
I know it is, Dan. You're good at that. So am I. So way back when, I mean, before COVID, obviously, and when I was with KP still in 2017, the reasons they weren't excited about it were many. One is one more thing for me to learn how to do. Leave me alone. We did one-on-one training for all physicians, advanced practice nurses, and PAs who did scheduled outpatient care, all specialties, all primary care, and gave them a $200 webcam. And a year later, after all that 30-minute one-on-one training, 70 had done at least one video visit. And the reasons were many. I would say the biggest is probably because it's not what they went to medical school for. And guess what? It's not what I went to physical therapy school for either. In fact, I chose PT over OT in 1978 because I wanted to lay hands on. It's a huge issue. So the other things were one more thing for me to learn. Some were afraid of technology. Some were worried the technology wouldn't work. Now with COVID, certainly they know how to do it. They all know how to do it now. I would make up, I have no data on this, that they still really prefer laying hands on patients because that's what they go to training for. And that's going to be a long time before that changes. Going specifically to your question, Adrian, let's go outside of KP, which is completely value-based reimbursement. For most of the world, that in the fee-for-service world, I think you guys have the opportunity to be more lucrative because I think you can see more patients. So one, you can see more patients. And two, I think now that the world has been introduced, the patients have been introduced to this, they're going to ask for it. And even before COVID, there was some percentage, it wasn't 50%, it was probably 25% or 30% that said, I would switch providers if I could get my care by video. This is before COVID. And it was not a small number. It was definitely double digit. And I'm sure that number has grown. So those two things, you can see more patients and therefore make more money. And there's nothing wrong with that. And two, patients are going to ask for it. They're going to depend on it. I definitely can keep going, but let you interrupt me if you want to.
What's your rationale for being able to see more patients? And I assume you're talking about physicians, not necessarily PTs.
So that's a good point. Let me think about PT.
And PT, by the way, PT is still fee for service. So
definitely
in most situations, and that's part of the problem that, excuse me, telehealth certainly is more efficient and it can be more effective in a value-based system. So it really is part of that solution. In a fee for service scenario where you're getting paid per unit or per time, it's a tough sell because you're basically trading off being able to treat or manage more than one patient at a time in an in-person setting.
Yes.
And that's one of the challenges, the financial challenges of telehealth. And it has nothing to do with quality of care.
You're right. And so I guess you're right. I certainly know this more about physicians, even though I'm a PT, not a physician. I know that they schedule 20-minute primary care appointments for in-person and for video.
Okay.
And they never use 20 minutes. And never obviously is an exaggeration, but rarely use 20 minutes. And certainly PT is very different. On the other hand, I would suggest we still do a lot of stuff that's how are you doing? How are your children? All that stuff that you move away from that. And the one other thing I'll say, Dan, and I haven't heard anyone doing this, but I would propose to you that you could still do, just like you do in person, hand off by video to a PT assistant or someone like that to do what they do in person. And they're in a different, like in a breakout room or something. I think you could still do that.
That's not a bad. Adrian, have you heard and we're talking about PTAs being a licensed PTA. That's certainly possible. I mean, PTAs can treat their own caseload by telehealth as well. So, that's always another option. Forgive me for being naive, but are most physician codes, are they time-based or are they completely procedural-based? Either of you
Guess
know that?
what?
I
am not an expert in coding. That's not because I was with KP forever.
Because I mean, that's a major. If you can,
it is a major thing.
It's a major factor. I mean, if you can see a patient, if you can do your 3 procedures in half the time of the next guy, you're going to make twice as much money, I guess. Hopefully your quality is good and you're getting the same diagnosis and treatment, or your patients are getting the same diagnosis and treatment. But point is that there definitely are efficiencies. My sense is that it's going to take a value-based system to really take advantage of that, particularly in the PT and rehab space, because it incentivizes the PT to be more efficient, be able to see 3 or 4 patients in an hour, 15, 20-minute sessions, whatever. And you can do that. I mean, you can get a lot done. Otherwise, you kind of, they're trying to build their codes.
So I obviously worked in a value-based system for 18 years. And PT was very different when I practiced it. Are you guys paid per time or per visit?
Mostly per time. Most payers is like per time.
Okay, so saving time is not to your benefit in terms of finance. I hear what you're saying.
There's no advantage to being more time efficient. Unless you can. Well, you still have to do.
Isn't there contracted rates? Aren't there contracted rates though?
There are. It depends
on the insurance.
It really depends on the situation. Certain payers are time based, and there's certainly are visit based contracted rates. I mean, sure, that makes sense. A lot of workers' comp is like that, particularly by self-insured employers. So that makes sense. Sure.
I understand what you're saying. Yeah. So if you could have a PT assistant working alongside you virtually, just the way they do in person, I think that would help you. I assume you could charge for the same time. I mean, the other obvious big thing is this is still going to drive value-based, is the remote monitoring world. And you guys know more about this than I do, I'm sure. But the fact that you could get in advance patient's range of motion. I don't know much about this.
Sure. Yeah.
Strength. And so imagine if you're in a value-based system, when I say you could do half of what you do before you even see the patient, I'm exaggerating, obviously.
Yeah, no. We talked about this with one of our previous guests. I think it was Anang, right?
It was.
Anang Chokshi works for a company, and they're working on technology to basically be able to monitor, to get what did he call it? Not vitals, but like physiological.
Movement data.
Movement data on patients. So when a patient walks into the clinic, the PT, and this is whether it's telehealth or in person, the PT is already well informed of what's coming to them.
I think the definition of the remote patient monitoring for physicians is it's a physiological one other category. And when I was with reactive, we were trying to figure that out, was that muscle strength, range of motion doesn't quite fall into that. I think what our last guest was trying to figure out is how to connect it to, or have a physician bill for it. So it gets reimbursed, but it's not, we don't have any remote patient monitoring metrics defined by the coding and the billing, by the CPT code. So I think that's a challenge with physical therapy currently, and then in rehabilitation. Once someone can inject you with a needle and it shows your muscle EMG, I think we'll have a better situation. But I think that's still a ways away for what we can do remote patient monitoring. But this would be more asynchronous treatment, virtual treatment.
Sure.
It's fascinating to listen to because there's no question about it. And if you disagree, say the word. But PT compared to MDs have a long way to go in terms of convincing the world this is the right thing to do. Is that fair?
Yes. Why do you say that? I mean,
just because in the last year, all doctors are doing it. And certainly in the last year, I don't think 100% of physical therapists are doing it. Is that fair?
You're probably right.
Yeah.
So I think that the number one thing for you guys to work on is proving the value one way or another of, for employers and payers, it's better outcomes, maybe better outcomes faster. You might want to talk to employers and payers to find out what is important to you. What do you want us to prove to you? What problem do you want us to solve, and how good do you need it to be to convince you this is the right thing to do? Once you've proved it, because it's pretty proven with doctors now, and it's not just doctors, obviously it's therapists and others, but I think PT is not as far along, is then I'm going to go tangential back to innovation for a second. The biggest thing I have taught when I led innovation, and I've taught it all over the country, mostly to physicians, is when you're leading innovation, I already said this, I'm going to say it again, you need to be very clear on a quantified problem to solve that's meaningful to those who want to do something different. So I say to you, when you're trying to convince people to use telerehab, what problem are they trying to solve?
Sure.
Do they need solved? So I would say the biggest one is the whole rural world of how long do people have to wait to get to see a PT? Not in Denver, but in rural, wherever.
Sure.
Define the problem. Ask them, work with people to define the problem. How bad is it? Are people waiting 3 months? Are they waiting 3 days? How good do they want it to be? And then you need to be able to prove to them that using telerehab, for example, could make that number go up or down, depending on which way you want it to go. Does that make sense?
I think that's one issue. That's not.
It makes sense. Like listening to it, it makes complete sense. But when you implement it in real life, that's a whole different story, right?
But to your point, Jan, that's not in some situations. The wait to receive your first physical therapy visit is probably an issue or a problem in some neighborhoods, some settings. But it's not always. I mean, in some communities, you can get a PT visit across the street, or you can, there's PTs on every corner, basically. And if it's not across the street, then it's another facility owned by the same company or the same healthcare system. So, for some that is an issue. For others, it is the access in terms of getting to a clinic 3 days a week. I think that's an issue.
Say more, Dan.
Well,
you mean
if you have a total knee replacement and your doc wants you to go to physical therapy, which, a lot of patients should have PT 4 or 5 days a week for the first month or so. And that's not happening for most patients. And when I say PT 4 or 5 times a week, I don't mean 2 hours each time. I mean, contact with a PT 15 minutes, maybe twice a week, and maybe 45 minutes, a couple of other days a week, just to keep the person focused. That's part of it. The patient, keep the patient focused, keep them progressing. Go ahead.
Let's go with this, my innovation process.
Sure.
So you're making this up, which is fine. Define for me the problem we're trying to solve and quantify it. You can use X for the number.
The problem we're trying to solve. Well, one is that, one problem would be the challenge for a patient to get to physical therapy 3 days a week. Let's just start with that.
So what's the challenge? Because they're at work?
I'm thinking of a 70-year-old person who's relying on, either public transportation or ambulance service or family members. So the inconvenience of all of that is a challenge.
Okay, I'm trying to think
Does
how
that
we can
answer?
quantify this. Yes,
So,
it does. It actually does.
quantify that. And let's just say it's still 3 times a week, right?
Yes.
And quantify you can quantify it in like the external costs as well as the actual cost of care. Care tends to go on longer if you're not getting the care up front. So if you're not getting it 3 days a week, you're doing 2 days a week, maybe you end up doing it for 12 weeks as opposed to 8 weeks. The number of visits and the number of procedures is probably going to add up. It's going to be more extensive. And, we all know that you heal more effectively in the earlier stages after.
So I love that. So your hypothesis is that when people don't get as much connection with the physical therapist as would be optimum, it takes longer for them to be back to normal. Did I say that approximately right?
Yeah, sure.
So suppose we had data, and I know you don't have data, but suppose you did have data to say that when people that are post total knee replacement I'm making this up. I have no idea. I only worked with kids.
Okay.
Take 3 months to be able to get up and down the stairs by themselves.
Yep.
Versus if they see a physical therapist as much as they need to be. Let's say they only can see him 1 day a week, and it takes them 3 months to be able to go up and down the stairs by myself.
Okay.
And then they get to see a physical therapist 4 times a week, whatever C means. Connect with a physical therapist 4 times a week. Then they can go up the stairs, up and down the stairs in 1 month. And sure. I would think that would be sellable. And that would be a hypothesis. You'd have to prove it.
I think it's not that it's the wrong question. I think we have to. What is the actual question? Is it consumer centric? Is it the patient that we care about, or is it the clinic practice? Because you're going to lose a profession if you say that this patient can get better on their own in 3 months, 1 time a week virtually, and the patient's okay with that. They don't have any rush. They're at home. Okay. We're assuming the patient wants to get better faster. Maybe they're tired. Maybe they're enjoying free time. Maybe they're enjoying not having to take out the garbage or do chores. So I think but then again, there are, and forgive me, I think Force Therapeutics, there's maybe on your blog, Dan, I'm sure, about knee replacements at home, virtual care being pretty similar. But then you can find articles saying that in-person PT is better than virtual rehab. So it's also kind of we're cherry picking sometimes in the data. But I think the question is, what do our patients want? What does our profession need, which is income and proper payment and parity and virtual reimbursement. But it's also, what do our patients need? What do they want? Because 2 months might be incredible when they've had 10 years of crippling knee problems. But then 5 months is great as well. Or maybe 1 month is incredible, So I think the question is really, it's so different because a 70-year-old in New York City and a 70-year-old in Montana who is on a ranch and really is self-sustainable to Colorado, right? So there's a whole different psyche behind what is good rehab, what is proper outcomes for individuals. And that's a hard question to ask because it's like apples and oranges. We're all assuming.
But Adrian, I think you're saying it perfectly. So it's the same with when you're trying to convince docs. Different docs have different points of view about what's important to them. It depends on your audience. So with that description of what you just described as someone who's really enjoying retirement, doesn't care about getting up and down the stairs by himself, what problem do you think you might be able to solve for that patient that virtual care would help? Or maybe there isn't any.
I think it's education. I think for the most part, people want to know what they can do, what they shouldn't do to slow down their progress.
Say it as something wrong that needs to be fixed.
What was the question again?
Okay.
Knowledge. So they're looking for knowledge.
I want you to say it as a problem. And again, I teach innovation.
It's like Jeopardy.
Big deal. You're right.
Say it in the form of a problem, Adrian.
What's wrong from a patient's perspective for which Tele would help fix it, you hypothesize? What's wrong?
Patients don't have the knowledge about appropriate care at home.
And let me push you a little further. And again, I've done this a ton with doctors. So what?
What do you mean? I mean, independence is crucial for rehab. For
what's that going to do for them? Adrian?
What difference if they're educated or not?
Do they want to be educated? I think that's Jan's question, right? Like, does the patient really? And every patient is different, obviously.
Yeah.
But do most patients want to know? I think most patients just want to get better. They just want to get back to what they want to be able to go to. 75, go to the bridge game, or walk with their grandkids.
All right, and that's what I'm saying. Is that we're asking the wrong question. We can pose the correct question. Is what I'm trying to get to. But I see what you're trying to say, and if we figure out what that solution is, or what that problem is,
let's go back a step. So I think that I like the quadruple aim or quadruple aim philosophy or theory on healthcare, right? So it should be to the benefit of the patient, of the practitioner. It should be effective, right? And good outcomes, and also cost effective. So to me, those are the questions that you have to answer. And I realize, Jan, every there are different people with different stakes in that equation, right? They each have their own. So the question really is, who are we trying? I mean, we're trying to accomplish that quadruple aim, right? So how does telehealth do that in physical therapy?
But it's going to be different answers, and it's not just for telerehab. This is for any innovation. It's going to be different answers for different stakeholders. So, for example, and this is the same for doctors or physical therapists. For payers, it's saving money. Money without getting worse outcomes.
Okay, so
that's what for providers.
I'm glad you said that. Hold on, let me stop you for a second.
Okay.
Telehealth use yields successful post-op physical therapy results. An Intermountain Healthcare study, Colorado, right, has found that Utah. Are they in Utah? Has found that physical therapy services delivered via telehealth for post-op patients produce similar outcomes to in-person care and at a lower cost. So this was a pilot study, so they had like 50 or 60 patients, right? Over 3 months of therapy, billed costs for patients using telehealth amounted to $1,015, while those using in-person services cost the system between $1,555 and $1,896.
That is what we need to sell to the
$500 to $1,000 more per case. They say the report I'm reading, in-person therapy visits are likely to include billable procedures beyond exercise and patient education, which increases the total cost. So they say that the outcomes were the same. This study says outcomes were the same. Costs were often close to double.
So it benefits the payer, right?
Benefits the payer.
Not the practitioner necessarily, right?
Right.
Okay.
Yeah, I mean, their purpose was to help people in rural communities get proper care. So they're saying that they can provide the same quality of care at a lower cost to patients who can't access care very easily. And part of the cost of transportation too. So
can you please send me that study?
Sure. I have yeah, go ahead.
My next question to Adrian or Dan is, okay, let's talk about from the clinician perspective, from the physical therapy perspective. What problem do you think you might be able to solve providing care by tele? Problem from a physical therapist perspective.
Well, you're getting paid either zero or something. That's the problem that tele. It's just an additional source of not as much as in person, but you're still not zeroing that visit. They're not canceling.
You're saying that cancellations are reduced?
Yeah. Okay. Potentially. Yeah, potentially.
That's huge.
So, and by the way, it's demonstrated and well known and documented. There's not a lot of data, but there are data very much so to say that the no-show rate for people getting telemental health is much lower than the no-show rate for in-person. And that could be the stigma might be different. So that's a big one, Adrian. I would say
that's definitely a big one. I agree.
Reducing the no-show rate and you don't get paid for no-shows, that's huge.
Yeah. Now, that's how you started, Dan, right? That was your idea.
Absolutely.
Back 2-3 years ago.
We had 15 or 18% cancellation rate at my old company. And I said to the CEO, Ed Mearsh, I said, if we could reduce that 18%, if we could reduce that 10%, it would contribute $1 million to our revenue per year.
Done.
Exactly.
And so when you have cancellations, you guys don't get paid?
No. You don't get paid for cancellation.
Done.
Who's going to pay for cancellations?
So we need data.
Yes.
I feel like
let's go back. Let's go back a step again.
And there's still resistance.
I think this is not an this or that question also.
Okay.
It's not in person or telehealth. Not in person or remote. We've said this before. I'm a huge advocate of a hybrid system. And there are just plugging in a remote care component, particularly in rehab, is so powerful because it, first of all, you're reducing those cancellations and no-shows. Secondly, you can have more touches with the patient, meaning they come into the office twice a week and you do one visit remotely. And it's so much just about access. What Anang said a couple of weeks ago was he used to give his cell phone to patients so that they could text him. Why not? I mean, what are we afraid of, right? And you can call that telehealth, you can call that remote access, whatever.
It is telehealth.
In a non value-based system, you're not getting paid for that. Okay. I mean, most states or most payers are not paying for telephone calls and text messages, but that's engagement, that's connection with your patient, that's continuity of care. I would suggest, it's huge. And this could be another quantifiable problem that you could hypothesize to solve is retention, patient retention. Sure. So I would hypothesize that physical therapists that are willing to share their cell phone number with their patients, especially younger patients, retain patients better than physical therapists that don't. It's just a hypothesis. I like it, Jan. We have a study. Jan's always looking to do studies. Jan's always looking to do studies. Give me some data.
Guess what? Data. My Myers-Briggs, I'm not a data person at all.
I know.
I am shoot from the hip, but I really believe we've got to prove this.
Yeah. No, and look, I'm not a researcher. I'm not a data person either, but somebody's got to prove it. And you're right. And look, there are several studies, just like this Intermountain one, that's huge. I'm sure it'll lead to bigger studies. Payers want to see it. Governments want to see it. CMS wants to see studies, research. It'll come.
Here's where I think the studies are out there. So we don't have the right narrative, or we're not doing something. The implementation, right? So it was knowledge translation is not there. We could all go on PubMed and find plenty of articles on telerehabilitation that it works, that it costs less money to the healthcare system.
There's a few.
Right? There's a few. There's enough.
I'd like to see them.
There's not a ton. There's a few though.
But there's plenty. I mean, it's an innovative practice. Okay. So if it's an innovative practice and there's already data out there, I really don't think, you started virtual care. I'm sure you have data you started what? How many years? 11 years ago at Kaiser. I'm sure they have plenty of data they can kind of just pull out just from that one health system. There's more health systems out there. So what I'm saying is that even though a physical therapist hasn't been a primary investigator on that literature, it's out there. And we just haven't translated that into actionable practice. And maybe there's something we have to kind of fidget with to make it more appealing to clinicians and to providers, to patients. And I think it's a different story that we have to tell, like Jan is kind of saying. But I think we always go back to data, prove it. We prove it. We prove physical therapy works, and insurance reimbursements go down. So there's not, we can do all the research in the world and the best investigators. It won't change, I think there's more to data.
So Adrian, I have a different point of view, and I don't know if I'm right or you're right, but I don't think we do have a lot of data. And I can tell you, even Kaiser Permanente, I don't even think KP's not even doing tele-rehab now.
I was going to ask you that. Were they ever? Right.
No, not in Colorado, and I can speak for Colorado. But even when I was there, and I'm still in touch with Ted Pauline, is a very, very well-known in KP Colorado internal medicine research physician. We haven't studied of whether we're getting better outcomes or lower cost. We haven't. The one thing we studied, and this is long before I was ever involved, when I joined KP in 1999, you already could email your own doctor, and it was secure. already in 1999. And they did a study to find out, what does it do to the utilization of patients? It increased the utilization of healthcare. So it increased the cost of healthcare. It took a long time for that to go away. And that's the only data we have. Obviously, that's a long time ago. Doesn't mean it's the case now. But so, Adrian, even if you're right, and I just haven't seen it all, I would be even willing to do this. Send me all this data and I'll write an article what the data says.
Send me the data. That's Jan's tagline.
Right. I want to see.
Send me the data.
Yeah.
Well, I mean but that's part of it is that I don't know if you have gone on PubMed and spent an hour looking for all the research. I haven't for sure. I've looked at every now and then. I remember this summer I was looking at data. I saw some stuff early, like several years ago with Force. It's weak. It's there though.
No, it's not.
It's there. It's almost like any new procedure.
It's not relevant. It's not relevant. And by the way, I am of a different opinion. I think the consumer is going to drive this eventually. I think that patients are going to demand it. They're going to demand it, and it's not going to happen overnight. It's going to happen when they go to all of their other physicians remotely. If they get a bee sting or whatever, they could see their dermatologist or get an antibiotic by telehealth. They want to be able to have the convenience and the access of being able to see their PT remotely when they want to, if they want to, when they want to, and get it paid for. And, when that happens, then payers will be forced to pay for it.
But I still think, and I don't know this for a fact, you guys, it's just my understanding, having been involved with telehealth, but mostly with physicians for so long, that I think rehab or PTs have a longer way to go to prove that what we usually do, everything is hands-on.
Good point. The biases are definitely in that direction, for sure.
Yeah, but I think it is provable.
Most PTs and patients believe that
you need to be hands-on.
You need to be hands-on.
The other thing is, you're not going to disagree with this, is reimbursement has to go along with it. And that's the same with docs. There's certainly, you're all getting paid now, but what's going to happen next year? Reimbursement needs to go along or nothing's going to change.
Yeah. And there have definitely been, there's lots of progress in that respect. A bunch of payers, United Healthcare included. United Healthcare just last week said, or 2 weeks ago, said that they're going to be paying for physical therapy services by telehealth. Same.
No way.
Full parity nationwide. So you can get your $50 a visit in office or by telehealth, however you choose to see your physical, treat your patients.
But Adrian, going back to like a half an hour ago, you said to me, give me the 10 bullet points. And so I'm going to go back to your question. I don't think I know the answer, but one thing you've said to me is the main bullet point to convince practitioners, physical therapists, to do this is the no-show rate. I don't know that I have another one based on what you've taught me, because they're not going to get paid except at United Healthcare.
What about the flexibility in their own schedule? I like that as a benefit for PTs.
Say more, Dan.
A lot of PTs are burnt out working in an office 40 plus hours a week.
Okay.
If they can break that up, maybe see patients 3 days a week in the office and maybe 2 days a week, whether it's in the office or remotely. It's just a different interaction, different way of treating your patients. So
how I would quantify that is I would love to see a survey. And you have to believe me when I say I'm on ENFP and Myers-Briggs, so against data. But I think we have, if we could get a survey to say of the 100,000 physical therapists in this country, 80,000 of them are really tired of going into the clinic every day, 5 days a week.
Adrian, this is one of Adrian's soapbox issues right here.
Okay.
PTs are burnt out. A lot of PTs are burnt.
But you're hypothesizing that the burnout rate would go down if they don't go in the clinic office every day. We don't know that.
Yeah. What do you think about that, Adrian? What's your thought on that? We don't know. You're right.
I mean, I've heard it from other clinicians, experienced and non-experienced, that they don't like sitting in front of Zooms either. So I think you're gonna find different personalities. Some people really I personally don't love this. I have my limits for seeing patients and even Zoom meetings where I create a boundary, but there's other people who love it. I know there's PTs who've been doing telehealth for years and they love it and they won't go back. And others are more open to it. So I think the burnout has way more to do with like just because United Healthcare is reimbursing you for telehealth doesn't mean your salary is going to go up and your quality of life is going to get better. So I think the burnout, we might again do a survey and see if clinicians are happier and have less burnout since telehealth became reimbursable by insurance companies or implemented into practices. But I think there's way more than instituting telehealth for some additional freedom to reduce burnout. Did I not answer your question?
No, and actually, it goes back to, so I'm just using this example, Dan. I'm not saying this is what you said, but if someone says to me, there's a very, very high level of burnout physical therapists, they're really tired, they're just tired. And then you say the solution is to allow them to practice by tele, I would suggest we don't know that would solve the problem. And that's what Adrian just said. We don't know. It might.
It is. It's definitely a theory that's being implemented in other areas of healthcare.
That's fair.
Right. And there may be some research, maybe some studies from other areas of healthcare. I'm pretty sure there isn't in the PT space. But I kind of like Adrian's angle on this, though, that PTs are burnt out because they don't get paid enough.
And is tele going to help that?
No.
If you can pay the same amount.
You weren't exactly saying that. I know.
But
I mean,
wait a minute. But if the no-show
double, they might be more willing to bust their ass a little bit harder.
Or 18% increase because the no-show rate goes down. It may come back to that's the biggest thing.
Not bad. Yeah. I mean, look, it's something that we gloss over all the time. It's kind of like an accepted loss, right? That there's going to be no-shows. There's going to be cancellations. And don't get me wrong, there definitely are no-shows and cancellations in tele also. Patients have other things happen. But it's definitely lower than in person. There's much fewer obstacles to get to your appointments.
And something I've been thinking about as well as, I agree with Dan, it should be both. It's not either or rehab or in person. I think it's both. And you just have to accept that that's the reality. But I think that physical therapy is an experience that many of us went into to touch patients and use our hands and be creative.
I did.
And so, right. And then patients also enjoy that experience and they like being asked about their job and their kids and their families.
Two different things though. Hold on. Those are two different things. First of all, I'm good. I don't need to touch any more patients. I'm good. But good.
That's you, Dan.
I know. No, but I'm saying exactly. And I'm giving the other side. I'm good. I've touched enough patients. I'm good.
And I'm like right in the middle.
But on the flip side, I love interacting with patients. I love it. That I like getting to meet people. I like meeting their cat and their dog too. I mean, I don't get to do that in the office. I think it's one of the coolest things. And my connections with patients remotely video are amazing. I mean, it's all face-to-face, one-on-one, half hour, 40 minutes straight. I mean, we're buddies, we're in each other's lives. So there's that, but go ahead. I'm sorry. I interrupted you. As Jan said, I'm very good.
Yeah, no, and it goes both ways. And as someone who used to never talk about personal stuff until I realized that that's going to help them improve. And then as someone who's a big time manual therapist, residency, SCD at Texas Tech. And then now I'm like, I don't have to touch anybody if I don't want to, I think that there's an opportunity as well to give everybody a little piece of that. I think we're, down the road, but I think it's the physical therapy is like a bunch of senses. You walk into a space and someone greets you and someone has their hands on you and it's comforting and you exercise and release, dopamine and all the great hormones and chemical receptors get heightened. I think there's something to be said for that. And before we kind of toss everything out, everything is virtual. I think now there's news articles and on CBS News all the time, like Zoom fatigue and how do you get over, don't look at yourself on Zoom. Like, those are like, come on, really? And so I think that there's something to be said with the old school, essentially when I say old school, but the old school, clinic, brick and mortar, talk to your therapist, get to know them and put your hands on them. So there's something that I've been thinking about recently, like why did therapists accept telerehab during the pandemic and then just went right back down to in person, but it's also the patients request it. And so that's another thing that I feel like if we can figure out that narrative, then that'll help kind of, improve our virtual rehabilitation.
there's room for both. And
I agree.
I think that there's value in both. That the smell of biofreeze is beautiful. I mean, it still makes me tear up.
I think the big things that I've heard today is one, see if you can find out where the highest no-show rates for rehab is.
They're
really?
They're in the Bronx. I can tell
okay.
you.
I don't
At Dan's old clinic.
Okay. And the other part is...
man, we managed it. We worked hard to manage it, to really make sure patients understood the value of what they were getting.
And the other part is, and this is no different than docs, and your no-show rate is probably no different than mental health. So talk to your mental health colleagues. It's dramatic. Sure. It's not quite the same because part of the mental health reason for decreased no-shows is because they don't have to face the stigma of sitting in a waiting room and everybody knows they're there to see someone for mental health. So it's not quite the same, but there's some parallel. And then the other thing is, where in this country do people have to drive the furthest to get to see physical therapy? I think those are your two plays.
Yes and no. I'll give you some flip side on that, Jan. Okay. First of all, utilization of telehealth tends to be higher in urban areas. Amazing, right? Amazing when you think about it.
Tele-rehab, you're saying?
Yeah.
Okay, tele-rehab, I don't know.
Good question. I'm not sure.
I don't think that's true for physicians.
And this was actually, this was from prior to the pandemic. Utilization. No, this was for physicians because it was from a webinar that I did during the pandemic. They had some health system. I think it was around, it might've been in Pittsburgh. It might've been
UPMC.
Yeah, UPMC. I'm not sure, but point is that all of their data showed that utilization was higher in urban areas for telehealth prior to the pandemic. That's medical. And part of the reason is the challenges of, transportation in an urban area. For a lot of people, they have to get a ride or they have to take public transportation. Whereas in urban areas, in rural areas, you get in a car and you go right up to the door.
I'm talking about rural areas though, and I'm going to have to look into that because that sounds very.
You can check my stats.
I'll look for data. So I'm talking about places that they'd have to drive 200 miles.
No,
to get
that I
physical
totally
therapy.
Understand. That
right,
I totally
that's where
agree
it
with.
really started.
Yep.
Yeah. Right.
The number, part of it might just be raw numbers though too.
Could be.
And I'm not sure about that.
Could be.
Because obviously higher population in urban areas, so more people are utilizing it in those spaces. Either way, I mean, I think that there's a need and an application in both situations. Yeah, I mean, Jan, you brought the goods today. I mean, you posed more questions than we did, I think.
I feel so challenged and tired.
I'm sorry.
It's great.
Awesome. I mean, look, we both enjoy the conversation. We both like being challenged in our assumptions, right? That we all. And I think it's important because it's such an open space right now and we really don't have the answers. So sure, like the more research, the more data, the more information we can get from patients, the better and the more effective it's going to make all of us. So, I still think that we should all be thinking about how to integrate remote care into in-person care systems and how it can make a brick and mortar or in-person system more effective. That's my philosophy on this. We usually end, Jan, by having our guests ask us each a question. I don't know. You got any more?
I'm going to just repeat what I've already said. And this is to anyone who wants to do anything different, whether it's tele or anything else. But
yes.
I've been focused on tele for many years now is what is the quantifiable problem you're trying to solve that you hypothesize tele could solve that problem and get the number from this number to this number, regardless of what you're trying to do. That's what I think you should be focusing on.
Excellent. I like it. Excellent conclusion. Adrian, you want to add?
It's not easy.
It's definitely not easy.
It's not easy.
All right, we'll wrap it up then. Jan, thanks for filling in today. This was sort of like a last second. Can I call you anytime someone cancels?
You can, and I would say to the whole world, I'm semi-retired. I really believe in telehealth, although I believe we need to prove it that more, prove the value. But I'm happy to help anybody anytime, not for money. janground@gmail.com. Let's do it.
That's great.
That's
Is anywhere else people should reach you, or is that just email you? janground@gmail.com.
Should I give my cell phone number too?
No, you don't have to do that.
Okay, you have.
That was last episode.
Thank you, Jan. Thanks for joining
Bye,
us.
guys.
Adrian,
Nice to meet you, Adrian.
have a good one, brother.
Bye-bye.
I hope you enjoyed that episode of the TelePT Connections podcast. You can find Jan Ground at Jan Ground on Twitter. You can email her, janground@gmail.com. And she's also on LinkedIn. Please remember to subscribe to the podcast, leave your comments, and we'll see you next week.
We hope you learned some things to help you connect with your musculoskeletal system and more. Find us on Twitter at @DSeidler, that's DSEIDLER, and at Adrian MPT, ADRIAN MPT, and on LinkedIn, Daniel Seidler and Adrian Miranda. We'll connect with you again next time.